It's great to be here with all of you. Greetings from Los Angeles, and I'm looking forward to the panel. The only challenge will be keeping it to the time because there's so much to talk about when we think about all the issues that we've been dealing with in the COVID era. But I'd love to kick it off by just asking both Bob and Michael, who have been at the helm of leading, the healthcare effort in New York. What was it like for you personally to be in the epicenter? What are the takeaways? Bob, you mentioned it was among the challenges you mentioned, you said the meanest year. So I'd love to hear what you had in mind when you were referencing that. Why don't you kick us off?
Out of respect, can I yield to Mr. Dowling?
Oh, thank you, Bob. Well, for me, it was a combination. It was a very humbling experience, and it was a reawakening. We've never been through anything like this before. And when you're in healthcare, you deal with difficult circumstances on a daily basis. But when you were in the middle of the COVID crisis, we saw about 85,000 COVID patients in our facilities. At one point, we had 3,500 patients in our hospitals, and these patients who were in the hospitals were severely, severely ill. We had on certain days at the beginning of April, we had about 90 deaths a day because we didn't know an awful lot about the disease. So when you're in that situation, and I was on every ICU in every hospital, I walked the floors of every facility. When you're in that situation, you realize how serious this was. You realize the inequity that was displayed by the people who actually were suffering the most, because it disproportionately affected people of color, minorities. And it also was a reawakening in this sense that it actually got me to think about, no matter what we did yesterday and how well we were doing today, we've got to do an awful lot more tomorrow. And that's a challenge, I think, for all of us. The other issue I just mentioned is I was absolutely astounded by the courage and the compassion and the dedication of the staff on the front lines. And I observed it directly because I was out there each day myself. And at the very beginning, this was a very difficult circumstances, especially in intensive care, where you had people on vents, and you knew that when you walked down the floor of a hospital and there were 20 people on vents, you knew that probably 60% of them were not going to make it. And I don't think, quite honestly, that you could ever be the same again after you went through a circumstance like this. But I do think it raises the bar for us as we go forward, that we should never again be as ill-prepared as we were as a country to deal with this issue. In our health system, we handled it pretty well, but overall, we were pretty ill-prepared. And I think it's a reawakening for what it is we've got to be doing tomorrow.
Thank you. That's very insightful. And of course, New York was the first one to be really hit with it. So you all really paved the way for the nation.
Yeah, we were at the real epicenter at the beginning, and it hit fast. I mean, it was very slow for a week or two, and then all of a sudden, in the case of 2 days, it just went from like 300 patients to 3,500 patients. Now I'm talking to people in the hospital. It does not include all of the thousands that were going into our ambulatory sites and our urgent care centers. Those people were not as sick. You didn't want to end up in the hospital when you were in this situation. You definitely didn't want to be in the ICU. And the last places you wanted to be was on a vent. That was not what you wanted to be. But at the beginning, we didn't know an awful lot about the disease. So we were learning. So 2 weeks after the first patients came through, we knew an awful lot more. So we were able to reduce the mortality over time because we learned more about the disease. And we've got to be prepared now for the next time. There will be another one, and it probably is not too far away. So we've got to be more prepared the next time.
Yeah, I have to say, from the community health center perspective, we're kind of at the other end of the healthcare spectrum. We do not have ICUs, we do not have ventilators, we're not hospitals, but what we do is preventive care. And I've got to say, beyond frustrating how crippled we felt in not understanding how one could help prevent COVID in those early days. Part of it was frustration over the clashing information getting from different public agencies, especially in Washington. But at the end of the day, our job is to keep people as far away from Northwell and other hospitals as we can. That's what we do. And that's what Northwell's primary care practices attempt to do. But the inability to be able to grab hold and do it right back in March, early April was beyond frustrating. And, Mike, you're right. We've got to do better this fall because, the numbers are coming up and we are heading into flu season. And, neither Mike nor I are clinicians, but I think we know enough at this point to opine like we are clinicians, but how we're going to be telling in our school health centers who has flu and who has COVID is going to be an incredible Herculean task.
Are you anticipating a second wave? And as you think about the fall, what's keeping you up at night?
Well, for me, we are seeing a little uptick in the numbers right now, obviously, because one lesson here is that masks work, by the way, compliance. If you comply with mask wearing, it does work, because we've observed that very, very clearly in the hospitals. But in the last 2 weeks, we've seen an uptick. Today, we have 132 patients in the hospitals. It's a relatively small number compared to what we had. So what keeps me up is every day that I get the numbers in the morning, I'm looking to see what does the number look like. And the thing that you worry about is that the number goes from 132 to 500. And now that puts, we're ready for it. We know what to do now. We're better prepared. But you don't want to see that number of people in the hospital sick with COVID. And this is why prevention is so important. Mask wearing is so important. Compliance by the public is so important. And I can say I've been out around the city and the region a lot recently, out in the communities, and I can say that most people are wearing masks. But there are communities that are not doing that, and that's dangerous because that just acts as the spread. And I don't want to get political here, but when you have national leadership, sending the message that you should do the very opposite to what science tells you should do and what good public health protocols tell you should do, it gets very difficult. But I worry about making sure we don't have a dramatic uptick. I don't think the flu season is going to be this bad this year, because in the Southern Hemisphere, when we look at all the data, the flu is very limited in the Southern Hemisphere, which is a predictor of what happens here. And that also is a result of mask wearing. So I don't think the flu is going to be as bad, but everybody should get vaccinated. We shouldn't, just because we don't think it's bad doesn't mean you shouldn't get vaccinated. You should for the flu. And then we're awaiting the vaccine for the coronavirus, which hopefully will be around at the beginning of the year. And then we have to figure out how to distribute.
Bob, your thoughts?
I don't want to be political either, much. And I kind of actually want to, share Elizabeth Crow-Kellner's optimism a little bit. I do think New York gets it. I fear for the rest of the country. But, most of New York is paying attention and complying with these life-saving safety measures. I think like Northwell in a big way, community healthcare network in a smaller way is better prepared, whether it's a second wave or just an uptick in cases. I guess it doesn't matter what you call it, but we pivoted to telehealth and we found it worked. We found that our behavioral health, our mental health patients are doing so much better accessing their care through telehealth. We were on a slow march to getting ready for telehealth back in February. I think a year, maybe a little bit longer. And by mid-April, we were there and it's worked. So I think we're good with that. I think we, now know how to safely bring patients in. I was very grateful that our team was able to get the personal protective equipment early on. We did not fight that battle like so many others. But, then again, whether we're a hospital system, a healthcare system, or a community health center, we kind of know what infection control means. Some of the worst problems were shelters, the congregate housing for people with developmental disabilities, social service agencies who had no idea what PPE was until the end of March and had no idea how to get it. So that was a real battle. The nursing homes are a god-awful story. But I think all of us, in New York at least, are in a better position to fight the next battle.
And I would add to what Bob just said about telemedicine. We were using a lot of telemedicine before COVID, but there were a lot of skeptics, including a lot of physicians that were worried about it, but it accelerated enormously during COVID. And I think it's going to refashion the way we deliver healthcare going forward. The access possibilities that can be created by the appropriate use of telemedicine, I think will be dramatically helpful across the board. And I think that the more we can articulate the importance of it and the more we can implement more of it, I think we will be serving the public a lot better.
I've certainly enjoyed it. It saves for the travel in LA and rush hour. So I think you're right that it probably is here to stay in some respects. Mr. Dowling, you mentioned the vaccine. Do you really think January is a realistic timetable, particularly since we just read that Eli Lilly and Johnson & Johnson have paused their clinical trials? What can we anticipate?
I think that it's possible by January or February. I mean, I think it's very important that science dictates this, that it cannot be driven by politics, which is unfortunate. That discussion has been going on. I do think, though, that it's quite possible by the beginning of the year to have it. And then the question becomes, how much of it can you produce fast enough? And then who gets it first and who gets it second? I'm now working very closely with the governor on trying to come up with a plan on this. And I think the priorities will be healthcare workers and essential workers will get it first. High-risk individuals will get it second. And then the question that we'll all have to put our heads together on is, what do we mean by high risk? Well, who fits into that category? And then I think the general public, and I warn people about this all the time, the general public probably won't be able to get the vaccine until the middle of next year, because after you go through the process of going through the first number of categories, you will be getting to the general public last. A couple of other quick issues. You have to store the vaccine in -7-degree temperatures. So you have to have enormous refrigeration capability to be able to do this. And not everybody has that. So we're working at that at the moment. And then you have to know, how do you train the people? Who does it? Who does the vaccine? Is it hospitals, community health centers? Is it CVS, et cetera, et cetera? So there's an awful lot of work to be done there. But I do hope that we will have something by the beginning of the year.
And in terms of the high-risk communities, I think there are two issues there. One is getting people into the trials so that the vaccine actually works for them. And then also, how do you build confidence in those communities that the vaccine is to be trusted?
Yeah, I meant to mention that one. This will require a lot of positive messaging and a lot of education because there is history with regard to vaccines, as we all know. And because of the politicization of the vaccine process over the last couple of months, people are quite fearful. So I think it will take enormous amount of communication. I had been working in to this point, about 11 of the minority communities in the region, working with the local pastors and the local churches on this, to work with them about how do we communicate about the efficacy of the vaccine and the validity of the vaccine and the importance of taking it. This will be a big issue because right now all polls suggest that there are anywhere from like 25% to 50% of the people say they won't take it. So this will be a remarkable communication process beginning in the spring. Actually, hopefully will begin in November and December about the importance of doing the vaccine. But if the vaccine is issued, if it's done right and science dictates, and people say this is valid and it has gone through the appropriate clinical trials, I think it'll make it easier. But if it's driven by the politicians, I think you'll have a big problem convincing people to take it.
Crystal, may I turn the table on you and Mike a little bit and play the journalist for the instant? I know each of you in different ways are very close with very close friends of Vice President Biden. Is there any inkling that you could share that there would be during a Biden transition and a Biden administration, credible scientists to do exactly what Mike just said is needed to get the thing out of politics and get reality and truth and science to the American public?
Absolutely. I think it'll be a whole new emphasis and orientation really being led by the scientists and also having a national strategy. So I don't want to get too political either, but I do think we'll see a very different orientation, very data-driven, people who respect the science and also believe that the federal government should really be leading in this effort and not just leaving it to different communities and state and local municipalities to come up with solutions on their own. I think we'll see much more leadership at the federal level.
I would like to that. I would think that you will see Dr. Fauci much more on the television talking about this. He's a very respectable individual, highly regarded by everybody, and he's been muffled recently by people like him standing up saying, we stand by what has come out and it is valid, it has gone through the appropriate process, I think will help enormously. That's what I would expect that we see happening.
And the independence of the CDC as well.
Well, absolutely, yes.
So Bob, you were dealing, your health centers with a number of these at-risk communities. Did it come as a surprise to you that communities of color would be so hard hit by COVID-19, and what lessons can we learn from that?
No, it surprised absolutely nobody who is in the healthcare business working with underserved communities. It is predictable unless we take some extreme measures, not just dealing with healthcare, but all of the social issues that impact healthcare. The next problem will also be inflicted on the same communities, the same people, the same death rate. So, we're always trying to find a silver lining in the nightmare of this 2020. Perhaps the exclamation point on the disparities in health, in life among our communities may be noticed by a few more people and may, perhaps in a different political system next year, begin to actually be addressed and not muzzled.
Just want to encourage people, if you have questions, please put them in the chat. We'd love to hear from you as well. So in terms of sort of large health systems like yours, Mr. Dowling, and community medicine, Bob, that you're focused on, how were you able to work together and what more could be done to increase those efficiencies and coordination?
Well, we work with a lot of community agencies. I think that there is a wonderful opportunity for CHN and Northwell going forward to combine our efforts here to figure out how we can help one another to reach out into communities, into the neighborhoods, and do a lot more work than we've ever done before. This goes back to what I said at the beginning, is kind of a reawakening. None of this is a surprise. We've all known it, but I don't think that we had it at the priority level that we should have had before. Now I think it will be disingenuous of us, and we will not be meeting our responsibility if we don't make it a major priority. I've restructured my organization in response, and as I said earlier, I've been out in these communities a lot recently, getting input from those communities and from people in those communities, so that they can help us figure out what it is we can be doing together more appropriately. I don't want to go in and say, look, I have the plan. That's not necessarily going to work here. But I think there is a real partnership that can be developed more intensely now between CHN and Northwell as a result of what we have to face and what has happened in the last couple of months. So we have to do better, and I just am hoping that we will all put our shoulder to the wheel and join forces on this.
Yeah,
specifics on what it means to do better?
I'm sorry, Crystal?
Any specifics on what it would mean to do better with that?
Well, let me give an example. You know, we're a little bit like the fly on Mike Pence's head. We're very small compared to everything Northwell can bring to the table. I have a fly flying around me now, which is why I said that. But I think it was not a coincidence that for the first time in many years, I actually saw Mike like this. He saw me like this at a Zoom hosted by the leaders of a number of Black churches in Brooklyn and Queens. We were deeply involved, you know, with the initial testing site, and that was with a church. And it's a church that we are partnering with. It's a church we're going to build a health center with. And Mike was there too, which they marveled at, because, you know, I belong there. The common understanding is people who are in major medical centers with 72,000 employees don't show up and talk to Black pastors. And I know, Mike, you did all spring, went to church to church to church to do just that. So that kind of advice that we're getting from the folks who are much closer to the realities that we're fighting, I think is a good sign that, be it Northwell or CHN, we're going to be in a place where we're listening and doing.
And both of your organizations have made statements that racial justice is healthcare. What does that mean, and what direction do you see that taking us?
Well, for me, it's for Northwell, it's stating a fact that racism, discrimination is a public health issue. It results in inappropriate access to care, inappropriate service, poor health, poor access to basic services in general. And I think I've got, you know, since I put out that statement a week and a half ago, along with a lot of other systems from around the country, I've got a lot of positive comments. I also have to say I've got some unbelievably negative mail about this. I can't say in a Zoom call like this what I've been called, but the more I get of that, the more that rationalizes the need to do what we just did, because it demonstrates the importance of making sure we highlight this as a public health issue. To me, it's a positive statement. Employees of Northwell have been overwhelming in their support that we stood up and said something like this. We should have done it beforehand. We should have done it a long time ago. But at least, you know, you can't go back. You got to go forward. And I think it is a recognition, just like a lot of things that we have witnessed this year across the United States. It's a recognition we have an institutional problem and we've got to address it. And those of us with some kind of influence have to stand up and say so, irrespective of the negative feedback you get.
I of course agree with that, Mike, and you know, have to say that I'm, as Elizabeth pointed out early on, relatively new to healthcare per se. Most of my work has been around human services, housing, food security, education, jobs. And the timing is good, because I think more and more there's an awakening that those are the issues that impact healthcare probably as much, if not more, than the quality of the physician or nurse practitioner you see in an exam room. So what I'm hopeful is that, given the relatively generous and incredibly inefficient United States healthcare budget, we will begin to recognize that those are the kind of supports that need to be provided, and we have to start providing those to the people who need them the most, which are not always, and not in every part of the country, but certainly in many parts of the country, people of color who have traditionally been left way behind.
I would completely agree, Bob, with that. I mean, about 70% of all ill health is due to the issues you just raised. I mean, we're very involved in food insecurity issues, employment issues. I mean, we're focusing an awful lot on communities because we hire a lot of people. We've got to be doing more there. A job is a health issue. Not having a job is an ill health issue. And we're going to see a lot more of this. The unfortunate thing with COVID, we will get the medical part of COVID taken care of within the next 12 months. The economic impact of COVID will, especially on these communities, will be with us for many, many years. And it's those things that will cause the biggest health problem. I mean, medical care is only a component of health. Health is all of these things that Bob talked about. COVID is not just only about the vaccine. The result of COVID is the unemployment and the lack of housing, the homelessness, the behavioral health issues that result from it. Unfortunately, that'll go on much, much longer and beyond when we have a vaccine and when we have a cure. This is why these issues have to be long-term. We can't just do project by project. We've got to focus on it over a long period of time.
That's absolutely right. And hopefully the definition of health is broadened now so that people have that more holistic approach. And you actually anticipated sort of one of the questions in the chat, which is really about the long-term implications of the children in distressed communities. What kind of long-term, short-term really, and long-term implications are we seeing there?
Yeah. Well, I think, I would say I'm not a clinician, but I talk to our pediatricians about this and our researchers, and they believe that because of all of the things that have been happening, the isolation, the lack of inability to go to school, for example, the unemployment, the family disruption that results automatically from that is going to have a long-term effect. And the other thing, by the way, with COVID, the fact that you come into a hospital with COVID and you go home supposedly you've survived COVID, there's going to be lasting health implications of the COVID crisis. We're finding this now, including employees. We lost 20 employees to COVID, but I've had a lot of employees that had COVID, so-called recovered, but they have lingering healthcare problems 5-6 months after having COVID. There are, there's brain issues, there's heart issues, there's, GI issues, all resulting from COVID. So it's multifaceted, and I think it'll take us a while to understand the full implications of it, even if it's only from the medical point. But on the children's aspect of it, financial dislocation affects families dramatically. And I think that we've got to be very, very attuned to that situation going forward.
I mean, part of the evolution of healthcare, and certainly of our organization, Crystal, as a result of COVID, really goes to the word trauma. I mean, what you described, the kids were all suffering from trauma, rich or poor for that matter, but certainly the poorer the kids, the more traumatic the experience. So, we begin talking, and, I'm not a journalist at this organization, learning constantly from our clinicians, learning from our behavioral health experts, that not only do we have to have trauma-informed care, we have to create for our whole workforce and our patient base a trauma-informed organization. Because whether it's COVID or the beating down day after day of life in poverty in America, we really do have to pivot into having that informed kind of healthcare. And, again, we kind of knew that. And if I can find something good about COVID again, I'll say it's been like a catalyzing force to really pay attention to some of these things that, we let go too slowly, I think.
Well, thank you. This has been a very rich discussion, and obviously you two are very thoughtful about all of these issues, and no surprise from Bob, Mr. Dowling, it's been great to talk with you as well. I know that the people who have tuned in are people who care about these issues. So as we close, I wonder if you might just give us some concluding thoughts about what we personally can do to help in these issues. A lot of us are not first responders, trying to keep our families safe, but is there more that we could be doing to move things forward?
Well, let me start by saying one is to encourage everybody that you come in contact with, that at least for the foreseeable future, to wear a mask and social distance when possible, because that will slow the spread. So we should all become advocates for compliance with safety standards. That's one thing. The other thing is to demonstrate to those around you that this is something that is a community issue, not just COVID now, but the implications of COVID, and that we're all unbelievably interdependent. We rely on one another, and we should be joining hands and unifying, despite the fact that we have a culture in politics at the moment that does the very opposite. that we unify. And the last point I'd mention is it's important here to be realistic, but it's also important to have an element of optimism that we can get better, we will get better, we will come out of this, and we will be better people as a result of it, and we will do things going forward that we should have been done in the past, but now we will make sure we do them over the next couple of years. So I would say deal with reality, be optimistic, and become an influencer in your community for proper behaviors.
Thank you.
So for my closing statement, what he said, absolutely right. And, you know, I don't think any of us have lived through such an era of division, not really so much in New York, although there's plenty of division in New York this past month, but across this country. I went back to watch the film Lincoln just to get a little more perspective and optimism about what's happening here. I do think if a pandemic teaches us nothing, it would teach us that we all are in it together. That if Mike doesn't wear a mask, he's endangering not just himself, but me and you and the kids. And if I am not keeping distance and I'm going to a party with my daughter's friends, we're hurting the commonweal. So coming together and kind of a night like this where many people have come together just sort of to, support Community Healthcare Network, a small organization, 80,000 patients, not anything like Northwell or some of the big hospital systems, but bit by bit, we all have to come together and try to, build bridges and try to bring folks who don't seem to want to get it to understanding. So maybe I should segue to the closing statement, which I think is on the timeline, which we are now 30 seconds behind. Mr. Dowling, thanks. It's such a pleasure and such I personally and organizationally very much appreciate your friendship and your time and help with our organization. And you need something, you know where to find me. Crystal, it's been a long time. It's terrific. Your firm was wonderful helping out with our legal analysis of some of the CARES Act. And you know that next time there's a crisis, we'll be calling on your firm again for more pro bono work. To all the folks out there who have supported us, thank you for the financial help. Thank you for the moral support. In a tough year. And we are grateful for you coming tonight. We're grateful that you have been with us throughout this year. Good night and good luck.